modern medicine has become a money machine designed to turn its suffering patients into lifelong customers. I'm Dr. Danish, a native Kentuckian and the visionary behind Wellward Regenerative Medicine. As a Johns Hopkins trained dual board certified anesthesiologist and pain regenerative specialist, I believe it's time to bring true healthcare back into medicine and offer you, the patient, the healing you deserve. This 50 Shades of Pain show is one way we empower you, the patient, to receive sustainable treatments for injury and pain without surgery, addictive medications, and without being a victim of the system designed to work against your body's healing. I encourage you to start your journey here at wellwardmed.com. Today I'm with my co-host, Dr. James Escaloni, who serves as a physical therapist and physician extender here at Wellward. Like myself, he's seen firsthand countless patients who have suffered unnecessarily, not for lack of qualified caring doctors, but from a broken healthcare system. So James, what are we talking about today?
It's a great question. So, for you guys at home, have you ever had a pain that seems to be sticking around and nobody can really figure out why that is? Okay, how about, has it been sticking around despite lots and lots of numerous treatments that should have been working but really didn't seem to? Have you ever been told by a surgeon, I guess we're just going to have to go in there and figure out what's going on? Well, this episode is definitely for you. So, every day patients are given MRIs and they're giving a blanket of diagnoses covering everything, but it doesn't seem to be helping and just adding more questions rather than giving you an answer. And what about any of you guys who've been told, well, it's just arthritis that's your pain? That is why you're hurting. Well, this show is for you. We're going to be talking about something called pain mapping. So, Dr. Danish, why is pain so mysterious despite all these advances in technology that are coming out in this new age?
You know, for such a long period of time, we've kind of conceived of pain being identifiable on an X-ray or an MRI, and that's just a very misguided approach, because X-rays and MRIs are often showing us what's happened in the past. They're not showing us necessarily what's happening right now. And when you talk about pain, you're talking about a multitude of different things. I mean, what's the reason we hurt? It's our body's way of communicating that something is wrong. So when you hurt, it's not as easy as to look at an X-ray and say this is the problem, because everything in your body is layered and it relates to each other. So like if I set a whole series of dominoes down and I knock one down, it's going to knock a series down. But the question then becomes is, which is the first domino? And that's not always evident off of the X-ray or MRI. Pain mapping is essentially taking each of those little dominoes and looking at them, examining them, seeing if the slope is right, seeing if when you set it back up right, if it stays or if it falls, but doing them individually until we get to the original domino, and then we can start a treatment plan that actually has some traction and can fix the problems.
So, do you think that the MRIs that are coming out right now are just not sensitive enough to pick out where pain is?
No, it's so yes and no.
Okay.
Because when we look at an MRI, it's not like the MRI is able to construct the body in 3 dimensions and give us the ability to look at various different layers at one time. It's cutting us into multiple layers. So if it cuts you straight down the middle like this, but the problem you have is going through that layer like this, rather than it being a nice full image of the problem, it's only going to be a dot or a line. So that's why all MRIs are made into various different cuts, going like this and going like this. And the radiologist is able to see that image in 2 dimensions. So you've compressed a 3-dimensional structure down to 2 dimensions. And if the problem falls directly in line with that plane, it's very evident and visible. But that's rarely the case. So radiologists are often looking for secondary signals, like is there evidence of inflammation, or is there evidence of fluid buildup, or is there a gap in tissue? Those are not always evident unless you get it straight down on the structure that's responsible. And the biggest challenge is that there are numerous structures in the body that are often in oblique planes. They're not going to be visible in any one specific image on an MRI or an X-ray. So it becomes very hard to visualize those things and identify them. Ligaments are, for instance, one example. Radiology will give you images of specific ligaments that have historically been operated on or treated, like an ACL or, for instance, a medial collateral ligament. These are evident on the MRI because we've built technology or we've built the system around those things. But when we talk about less known ligaments, like we talk about the coronary ligaments in the knee a lot, or the glenohumeral ligament in your shoulder, or the multiple ligaments that you have in your hip, all of these things can have problems in them, but because they're in curved planes or they're tangential or oblique planes, meaning that they're diagonal instead of straight up and down, they're very hard to visualize on an MRI or an X-ray.
So I've read a little bit about MRIs that are lying down versus MRIs where you're sitting up. Do you think that plays a role into some of the patient's pains that you can't find?
That's a great point, because most people who have back pain, for instance, it's not that they hurt when they're standing, when they're laying flat. It's they hurt when they're standing up or they're moving around. But an MRI isn't going to catch that because most MRIs are built around people laying flat. And that's not in a position that's going to put enough stress or strain on your back to really make the problems visibly evident. Now, they have developed new technology where you have stand-up MRIs or seated MRIs, but the problem with those is that the quality of the image is much, much less than the traditional tube-based MRI. And they're harder to find. It's not something that insurance will reimburse more for, despite the higher cost of running those kinds of machines. So typically they're used for research purposes rather than for daily diagnosis of different conditions.
Oh, I didn't realize that. Well, what about for some of the patients that we've talked to that they get an injection and it seems like that should be the spot, but it doesn't seem to hit its mark? What do you think about that?
Yeah, a lot of the advent of image-guided injections is really fairly recent. It's only been in the past like 15, 20 years that image-guided injections have really become prominent. Before that, it was all done based off of feel and anatomy. And while people who do that on an everyday, daily basis can become very, very good and astute at finding the different locations on anatomy, even under image guidance, I'm always amazed when I look that when I think I'm in the right spot based off of my anatomy, I'm not always at the right spot. And there are some structures that are much, much more nuanced. Like the difference is an eighth of an inch between structure 1 and structure 2. And in those situations, it really becomes hard to get a pinpoint accurate placement of medications unless you're directly visualizing it. And the most innovative thing that has happened in the past 20 years in managing pain, to me, has been diagnostic ultrasounds, because historically we've only been able to look at bones and the connections to bones, but soft tissue like muscles, tendons, ligaments, nerves, these were all invisible to us because we couldn't see them with a standard X-ray or even the live X-rays that are often used to do image-guided injections. So around 2011, 2012 was when we really invested heavily into ultrasound technology in our practice. And for the past decade, we've really honed our craft, and it's one of our expertise is to use diagnostic ultrasound to visualize the soft tissue, where we're finding so many more problems exist than previously we thought about. Because frankly, if you don't have a lens, if you don't have a microscope, you're not going to see the bacteria. This is the same thing. If you don't have the appropriate lens for visualizing the body, being able to see it, being able to navigate through it, you're not going to find those things.
So I remember a couple episodes back we talked about how ligaments can be a source of pain and even refer pain down the legs. And it also sounds like on MRIs, sometimes they don't pick up that ligament might be a source of the pain. So what do you do that's different?
So when we're using the diagnostic ultrasound, we're using it for two purposes. One is to just see the anatomy in its native form. Like if I'm laying down at rest and looking at somebody's elbow, or sorry, the other way around. If a patient is laying down at rest and I'm looking at their elbow, at rest, I'm looking to see if there's any evident gap in the tissue, any swelling, any tears in the ligaments or tendons. But what's even more helpful is because the ultrasound is in real time, I'm actually able to say, okay, well, let's get you in a position that actually hurts. And now let me look at it. Or let me stress this joint. So if elbows are only supposed to go this way or this way, they're not supposed to go this way. And you can imagine what I'm talking about. So if I stress the elbow in that way and I'm looking at it, I can actually see the gap in tissue where there's a tear in the ligament, something that would be nearly invisible on an MRI unless the radiologist got the image perfectly aligned with that ligament. But when I'm looking at it in real time, I mean, I can move this way, I can move that way, and I can hone the image exactly to the structure I'm trying to see and visualize it in multiple different directions rather than just one.
Okay. Well, that sounds like it's going to be pretty helpful. But it also sounds like there's a lot of different things that are going on all at once. How does this organize so that you can actually help out the patient without having to take forever and even get to a good conclusion?
So that's where our pain mapping really comes in. Pain mapping is a concept we've come up with, which is using the symptoms of pain to really map out the body and figure out where those domino pieces lie and which domino is problematic. In pain mapping, we start with getting a very detailed physical examination and history, looking at all the different problems that have taken place in the past, getting a full understanding of the surgeries or treatments that have been done in the past, because each one of those is going to change the anatomy. And until we get a better understanding of what to look for, it's really hard to figure out what the problems are. So after we get a good baseline assessment of that individual, then we want to look through the body with the ultrasound or x-ray or fluoroscopy, which is live x-ray, and see the body in its native state, visualize it when it's not under any stress, and then put it under stress and visualize it again and see where those tissues start to lose their integrity and where gaps start to develop, and think through the mechanisms of that. Because if for instance, I have a gap in tissue here, where else is that going to be affected? Knee, for instance, if you've got knee pain on the inner part of your knee, you're going to shift your weight to the outer part, and that's going to put more stress on your hip. So all of these things are related, and we want to start building a map of, okay, if this is a problem here, what else could be affected from there? Once we have that rudimentary map, then we go through and systematically target each one of these potential problems and in some way change that. So in some situations, we want to inflate it to take up any slack and create a temporary artificial stability there, and then retest the structures and see if it's any stronger. In other situations, we want to just simply numb it and see what happens to the pain. How does the body adapt to that or change with the pain that they were having before all of those examinations. And then once you have all of that down, then you go back and do the examination, the physical examination again, and see what has changed to determine among these different elements that we've addressed, what has been problematic.
So if I understand that right, they come in, they get a hands-on physical exam, and there's a few things that could potentially be wrong. Then you double check that against some sort of imaging. Then you triple check that with some sort of medication that could potentially numb it. Then you quadruple check that against the first testing to see where the problem was, see if it's different.
Right, exactly. So, I mean, there's no way that insurance would allow for that level of comprehensive evaluation. There's so many things. One of the biggest qualms I have with healthcare is it's just fractured. We are forced to do things in small, discrete episodes of care where the continuity is not there. Essentially, it's kind of like playing that game of connect the dots, where the dots are just so widely spread out, and then doctors are expected to be able to see the full picture without ever being able to draw those lines in between. Pain mapping circumvents all of that. We get around all of that by putting all the dots on one page and then starting to connect all of the dots so we can actually make sense of the image that's being seen. That the deficit in healthcare is because we're not able to see the picture with the lines, we're having to go on the dots. A lot of people get treatments or surgeries or diagnoses that are completely inaccurate, and that just sets them up for failure. So when people come to me and they're just at that point of desperation, they're just feeling complete despair over their condition, it's not because they didn't have caring doctors or they didn't have intelligent doctors or they didn't have insight into what was going on. It was that they had a smattering of dots which were connected in some way, but there was no mechanism to be able to create those connections and really visualize the whole picture as opposed to just the individual dots. So when we do a pain mapping session, we're building that whole picture and we're giving that to the patient. Because I find that people are very tolerant of really awful sources of pain if they know what it is, if they know what the course is, if they know what to expect coming up down the road. Their tolerance for that just goes up dramatically.
This sounds pretty revolutionary, but also sounds like it could take forever. How long does a pain mapping session take?
Pain mapping session can take an afternoon. It can take some time, but a lot of times these are situations in which people have failed the basic workup, and so we want to compress all of that knowledge in the span of a single day, where at the end of that day the person has a solid understanding of what's going on. So it can take anywhere from 30 minutes or it could take 2 or 3 hours, but it just varies depending on the condition. However long it's going to take is however long we're going to spend on figuring it out, even if it's something that we have to have them go and come back and evaluate down the road.
Wow, I hear you. That's pretty good. So is this something that has always been a part of WellWork?
This has been something that we've been doing for a long time, but we've really honed the craft more recently. I mean, I really value Dr. Escaloni's presence in our clinic because he provides a perspective that I wouldn't have on my own. Your ability to examine the patient and get the mechanics of what's going on, the training that you have in that space is so much more robust than what we see in medical school and in residency. So bringing those two entities together and combining them is, to me, very powerful.
Well, I think that I definitely appreciate those super kind words. And I think that coming in here and having a better understanding of the HEAL philosophy has made it easier to treat patients and understand that there's an easier and better way to help patients out. So the HEAL philosophy, do you care to touch on that? Yeah,
HEAL is the methodology that we use in our practice. It's a 4-staged methodology. It stands for hearing the message that your body's trying to convey with pain. So essentially pain mapping, understanding that when the body hurts, it's hurting for a purpose, and we want to trace the pain or use the pain as a detective would to find what the underlying problem is. Envisioning what life is meant to be, because a lot of patients who have been dealing with chronic pain, they start cannibalizing parts of who they are, parts of their identity, to accommodate the pain. And so over a period of time, people lose the sense of who they are. They forget what their true sense of self is, because the focus has been, let's figure out this pain issue. So we want to re-envision what life is meant to be like. We want to alleviate the symptoms, the third step, which means to reduce the sensitivity of pain, turn the volume down in the brain, because if I keep poking you in your arm, over time, even if I didn't cause tissue damage, it would become more and more sensitive simply because that nerve is being constantly fired. And then finally, leverage what your body does in its normal state to repair and figure out what are the obstacles why in this situation your body's not able to repair itself, and then leverage those repair mechanisms so that it actually is able to repair.
That's pretty amazing, really. It's a fantastic practice right here. Glad to be a part of it.
We're happy to have you.
All right. Yeah, I think that covers what we really wanted to understand about pain mapping today. So definitely thank you very much for going into that with greater detail.
My pleasure. Thank you for watching this 50 Shades of Pain show. Each patient is different, and there are numerous factors that can contribute to your pain. In the same way, we recognize each patient as individuals and create treatment plans designed specifically for your health. Our Wellward team looks forward to partnering with you. I'm Dr. Donish,
I'm Dr. Escaloni.
and we encourage you to start your healing journey at wellwardmed.com. Thank you.
Bye.